Okay, welcome everyone to this spotlight on automated insulin delivery in pregnancy. If you're not here to listen to pregnancy, this is your opportunity to escape. If you are here to listen, we're delighted to share with you some of the really groundbreaking revolutions we've seen in the diabetes technology space in over the recent years. So my name is Helen Murphy, and I am a clinical scientist, been working in this space for about 20 years now. These are my disclosures. I will stress that all of our research is independently funded, and whilst we receive device support, sensors often at reduced or at a research cost from various technology companies, we remain device agnostic. At every stage in our work, we choose the best technology solution for the right population of women at the right time. For those who are not so familiar with working in pregnancy, 1 in 2 women will still have large for gestational age babies. These large babies are very often delivered preterm. They are much more likely to be admitted to neonatal intensive care units. For the mums, they're associated with birth injuries, and birth injuries is the leading cause of medical legal litigation in the UK, taking up more than 4 times the entire maternity healthcare budget. So anything we can do to reduce the risk of large babies, to reduce the rate of birth injuries, will allow us to spend more money on care. And over the longer term, it will reduce these babies' risks for the life course problems with obesity, cardiovascular disease, type 2 diabetes, and increasingly recognized neurocognitive disorders. Aiming for tight glucose levels in pregnancy is absolutely crucial for to minimize the risk of obstetric and neonatal complications, and the pregnancy glucose targets therefore are much tighter than targets outside of pregnancy. 70% time in the non-pregnant range equates to only 45 to 50% in the pregnancy range. This is an order of magnitude difference that is really challenging to achieve. And over the last 15 years, we've been working closely with engineers, Roman Havorka in Cambridge, to develop pregnancy-specific algorithms that are fit for the gestational challenges of pregnancy. Here at the EASD last year, we published our pivotal trial called the ADAPT trial that gave unequivocal evidence that women who use pregnancy-specific hybrid closed loop are much more likely to achieve the pregnancy glucose targets. Specifically, they achieved a 10.5 percentage point increase in time spent in the pregnancy target range. They did that very, very quickly, within days, such that by the end of the first trimester, there is a clear day and night difference between those who are using standard insulin delivery with real-time CGM compared to those using automated insulin delivery, and that difference persists right across pregnancy. You'll see that the difference is also there right across the 24-hour day. So whilst the maternal mothers spend much more time in target overnight, this is not a system that just gives a little bit of extra overnight. It works over the 24 hours, and that is because of this uniquely adaptive algorithm. This is also not a system that just benefits some women. This is a system that works across all women, regardless of the baseline glycemia. So the treatment effect, that 10.5 percentage point increase, is equally applicable to mums with HbA1cs between 6 and 7%, to those between 7 and 8%, and those with 8% and above. This means that this is a system that is applicable for a nationwide implementation, not just a system that can be used in selected women by selected centres. It's also a system that works equally well for women with previous device experience and those with none. Half of the study participants used insulin pumps, half of them used multiple daily injections, and a small number used other AID systems. In addition to those clear benefits for maternal glucose that lasted from the first trimester through to delivery, women had remarkable quality of life benefits. And for those of you who have type 1 diabetes, it is worth reading those papers. For those of you who remain unconvinced about the difference this can make to the lived experience of women with type 1, or those of you that think it's too hard to do something new in your already busy clinic, please read the qualitative papers. Offering women the opportunity to improve the health and well-being of themselves and their babies is an enormous privilege, and no one should be too busy to offer high-quality care to pregnant women. Some of the additional biomedical benefits that were unexpected is that women gained less gestational weight, 3.7 kilos less gestational weight, because the insulin delivery was more targeted and precise. That's about 8 pounds and 8 ounces. Now that comes with real health benefits for the mum and for the baby. It also came with a lower risk of gestational hypertension and some of the lowest rates of large for gestational age babies and neonatal intensive care units admissions that we have ever seen in a representative population of women with type 1 diabetes. It was on the basis of the ADAPT trial results and within 3 months of the primary publication that the NICE guideline committee produced what we call a technical appraisal recommending hybrid closed loop as the treatment of choice for all pregnant women with type 1 diabetes. And you may see that increasingly other hybrid closed loop systems may be used with very good effect outside of pregnancy. And we believe it's quite safe for women getting pregnant on other systems. Those other systems target 3.9 to 10. They were not designed for pregnant women. They do not have a background of 15 years of research, tweaking them and checking them against all of the gestational challenges. So if you read the results of these 2 pivotal randomized trials, one using the pregnancy-specific CamAPS system, the other using the very well-established Medtronic 780G system, you'll see that the ADAPT trial incorporated a very broad patient population, 124 women, aged 19 to 44 years, BMIs between 18 and 49, HbA1cs at entry between 6 and 14%, half of them using MDI, and an independently peer-reviewed study funded by our National Institute for Health Research. On the Medtronic side, the Belgian study predominantly led in Belgium. 96% of participants were existing pump users. Women were aged 30. They had far lower BMIs, and they had a mean A1C of 6.5%. Now, remember, I just told you that the participants in the ADAPT trial with A1Cs between 6 and 7% still had a 10.5 percentage point improvement. Unfortunately, the women who continued using the Medtronic 780G, despite their excellent baseline glycemia, had no improvement above and beyond what you would expect from a pump and a sensor alone. So there was no additional gain for using this during pregnancy. There was absolutely no harm in using it until the time of the first trimester, because it is a system that can well target 3.9 to 10, but it's not a system that adapts to the gestational challenges of pregnancy. And we've seen recently some real-world data from Spain, from a group of people with no skin in this game, I would say, who outside of pregnancy compared all of the hybrid closed-loop systems and found no significant differences. So if you're targeting the 3.9 to 10, it really doesn't matter if you use the Medtronic 780G or the Tandem. It can come down to patient and clinician choice. But when it comes to pregnancy, take a close look at the results of these 2 studies. So using the pregnancy-specific CamAPS system, 1 in 2 women achieved the pregnancy glucose targets from 16 weeks gestation until delivery. The women who did that had 3.7 kilos, or 8 pounds, 8 ounces, less gestational weight gain, and an LGA rate of 39%. The participants using these other systems, and if we look at those, especially at the participants with HbA1cs of 6.5% and above, only 5% achieved the pregnancy glucose targets. They achieved it with increased gestational weight gain. On average, 3.3 kilos, but for those who entered pregnancy with HbA1cs of 6.5 and above, that was 5.4 kilograms. Now you can do the maths and add 5.4 and 3.7 and begin to think of what a difference that will make for these women and the babies. The LGA rate on the other systems was 69%, and that speaks for itself. So if you work in pregnancy and you want to use a system that's going to give women the best chance of achieving the glucose targets with the lowest risk of large babies, there is at the moment only one choice. The other systems do get there, but they do not get there until right at the very end of pregnancy, much as we saw in our concept study of CGM alone. So they will get to the pregnancy range, but they don't do it until 32 to 36 weeks. And that is too little, too late to improve mother and baby outcomes. So, in summary, we have a system for the first time, a pregnancy-specific system, which we define as a system that has a license for use in pregnancy, a system with a glucose target of less than or equal to 5.0 millimoles per litre, or 90 milligrams per deciliter in US units, and a system that must surely offer women the minimum of 5 percentage point improvement, not a system that offers them nothing above and beyond a CGM and a pump. And this again summarizes some of the additional benefits for mums and babies. Less weight gain compared to other systems, and babies who also have less weight gain compared to commercially available hybrid closed-loop systems that have not yet been refined for pregnancy. So across the UK, in all maternity clinics, of which I believe there are 184, we will be issuing strong clinical advice to women and to diabetes pregnancy teams that it is absolutely safe for women to enter pregnancy on any hybrid closed-loop system. And that will help many of them achieve the target of 6.5%. But what it will not do is help them adapt to the gestational changes of pregnancy, for which there is only one system with a glucose target low enough and a documented evidence of improved time and range in pregnancy. So we will be specifically stopping all other hybrid closed-loop systems and recommending that women take up the CamAPS pregnancy-specific system as soon as possible in pregnancy, and of course, ideally, even before pregnancy. And you'll hear a lot about what we call politely barriers or perceived barriers. These are actually excuses. Patient choice. The woman likes the color of this pump. She doesn't want to have a tubing. Well, go tell her she might gain an extra 10 kilos and see whether she will be happy to have the tubing. Tell her she can continue the other system, but it will not reduce the harm for her baby. Ask her if she wants to have a large baby and she's willing to take the risk of a birth injury. I have not yet met a pregnant woman who doesn't want to do the best for her baby. These are excuses. An incompatible phone. Get over it. The cost of a phone compared to the cost of a birth injury is trivial, and we can work these things out. The biggest excuse is clinician inertia. And I would say to you, this is simply not good enough. If you believe in evidence-based medicine and you want to make a difference to the lives of women and babies, then you organize your teams and your systems to deliver high-quality, evidence-based, proactive, prepared care, and you overcome these non-barriers and excuses that get in the way of doing the right thing. And it's not difficult. Pilar will talk how to do it. Everything you need to know about how to do this can be summed up in very simple 5-minute videos. It doesn't take more effort for women, and it doesn't take more effort for diabetes pregnancy teams. Women using pregnancy-specific hybrid closed-loop had fewer visits, fewer contacts. Take-home messages: there is one pregnancy-specific hybrid closed-loop system that improves maternal glucose. It does it within days. It works during pregnancy. Actually, it works even better after pregnancy in the postnatal setting. And we, all of us who work in pregnancy, need to start organizing care in a better, proactive, prepared way to ensure as many women as possible enter pregnancy on the system. Those who don't should start as soon as possible in pregnancy, and no one should ever take it away from them after pregnancy. Thank you for your attention. I just acknowledge the entire team who contributed this work over 15, 20 years. And I'm delighted to pass on to Pilar, who's going to tell you the experience of using the system from someone who's come to it more recently than me, but also with no skin in the game and a fresh perspective that I hope will be really helpful to people who are starting out on this journey. So welcome, Pilar.
Thank you. Good morning, everyone. Thanks to Ypsomed for the invitation. I'm honored to be here with Professor Helen Murphy, sharing our experience with the CamAPS system. First, from our perspective as healthcare professionals, we've been using AID system for some years now. We have more than 500 systems in our clinics, meaning around 50% of our people with type 1 diabetes, something we're very proud of. And we've been lucky enough to be able to share our real-world data. So when the CamAPS system was launched here in Spain 2 years ago, we had to decide if the systems already in the market were enough or if we should challenge ourselves a bit more as a team and incorporate into our practice this technology that was completely new to us. So first of all, we considered who could benefit the most from this system. We talked to our pediatricians and we agreed to select the little kids and the women planning pregnancy to be the first ones to try the new system, because although both are extremely challenging population, neither of them had approval for AID systems. So the pediatrician started with the little kids. Of course, the parents saw the small size of the system as a huge advantage, especially in these tiny babies. And we started with the women planning pregnancy. We knew that we were going to be learning at the same time as them and extrapolating our experience with other systems. I've been myself doing the pregnancy clinic for years, and we all know how complicated it is to reach these tight targets if you want to optimize the pregnancy outcomes. We had read the ADAPT study with its impressive results in pregnancy. And we had heard Helen Murphy at the EASD and ATTD explaining how this system had been specifically designed for pregnancy and how it should be offered to all women before or during pregnancy. Apart from other reasons, because this system gives us the option to set low glucose targets when needed, especially in the second part of the pregnancy. So we designed a protocol with what we call a pre-training session in clinic, where we check the phone compatibility and we download the app so the women can practice at home. And after that, the initiation session, normally in groups, if possible, where we explain all the details of the system and where we start auto mode. I said that this is a challenging population, but it's also a very motivated population. They were happy to be offered a system specific to pregnancy, and it was really nice working with them. So now, in total, we have initiated 32 systems, 60% in adults, 40% for pregnancy, in people coming from NDI, from pump therapy, or from other systems. And we presented our first experience at the ADA in June. So, focusing now on pregnancy, what we have now is 6 women in preparation for pregnancy, 2 women are now pregnant, and 4 women have already had their babies. 5 of these women came from MDI, and the rest switched from other systems. And 3 of these women initiated the CamAPS system already in pregnancy. We've been using both sensors, Libre 3 and Descon G6. And I'm going to present 2 of the cases. I've selected first the most challenging one you will see, and second, in some way, the easiest one. So first case, her name is Irene. She is 22 years old. She's had type 1 diabetes since the age of 12. She had a history of recurrent DKA. On NDI, her time in range was 34%. GMI was 9.5%. She used the sensor only 43% of the time. Her glucose profile and her HbA1c, unfortunately, 14, 12, 10%. And she came to the clinic saying that she was 13 weeks pregnant. This was mid-August last year, and she was very, very upset and very, very scared. We decided to initiate the CamAPS system as soon as we could. She learned very fast. She said that the app was so simple to learn. And this is when we initiated Automod. First, the previous days on NDI. And now in Automod, you see an impressive improvement in glucose control to go from 38% time in range, and this is gestational range now, to 62% time in range in the first 2 weeks of use of the system, 60% in the second trimester, and 65% in the third trimester. GMI was 6.5%. She had never had this glucose control before. Her glucose profile, very different to the previous one. And when we congratulated her on how well she was doing, she just said, "It's just that now with the pump, it's as if I wasn't diabetic anymore." This is when Irene had her baby. She was in Automod all the time, and she had a baby boy. His name is Miguel, 37 weeks, normal weight, no hypoglycemia. The second case is completely different. It was a planned pregnancy. Better, it was an extremely planned pregnancy. Her name is Jael. She's 33 years old. She's a primary care physician. She had been using a closed-loop system for 2 years. She had a history of 2 miscarriages, and she was planning a new pregnancy. So in this situation, we thought that the best option was to switch from the previous system to the CamAPS system before pregnancy. And she went from an amazing 81% time in range with the previous system to an even more amazing time in range of 86% with the CamAPS system. She got pregnant. You're going to see her glucose control during pregnancy. This is gestational range. First trimester. Here we reduce the glucose target. I'll explain in a minute. Second trimester. Third trimester. And 40 weeks. She was determined to reach the 40 weeks, and she did with an amazing 93% time in range. So excellent control throughout the whole pregnancy with no hypoglycemia. This is her daily detail, the ease of function, the boost function. We encourage the use of both of them during the pregnancy. The women are going to use them anyway, no matter what we say. One of the women said that the boost function was her favorite one because it helps control hyperglycemia very nicely. This is when Jael had her baby. Again, she was in auto mode all the time. Now the nurses in the maternity unit understand that they have to let the women keep their mobile phones with them all the time. And she had a baby girl. Her name is Vera, 40 weeks, normal weight, again, no hypoglycemia. Regarding glucose targets, what we did with Jael was to go from 90 milligrams per deciliter before pregnancy and in the third trimester. Normally we use more than one target per day, to 80 milligrams per deciliter in the second part of the pregnancy, and to go back to higher targets after the baby was born. Actually, with Jael, it had been a bit different. We had been a bit less aggressive with Irene than with Jael, because Irene was our first pregnancy, and it took us some time to learn and to feel comfortable with low targets and to see that they are safe and that the risk of hypoglycemia is very low. So, summarizing the settings in both pregnancies, we were progressively reducing glucose targets and carb ratios and adjusting body weight. And after the baby were born, we did exactly the opposite, to increase glucose targets, to increase carb ratios, and to adjust body weight. And these changes after the babies are born are very important to avoid what happened to Jael, that she forgot to increase the target after the baby was born, because she was busy with the baby and she only realized it when she started having hypos. What we do now is to teach the husbands, the partners, how to change the settings in the app, and they like that because they feel involved and they feel that they are being helpful. And finally, our outcomes. The nice comments we've had from the women: thanks to my new system, I'm enjoying this pregnancy. It gives me peace of mind. This pump has changed my life. Our babies, you know Miguel and Vera. We also have Paula and Elena, all born with normal weight, healthy babies. One of the husbands said, I think this way of managing diabetes is very clever. I'm sleeping better myself. And this specific comment from one of the nurses in the maternity unit, even though she didn't know much about closed-loop systems, she said, after examining one of the babies, she said, this child is better than if her mom didn't have diabetes. And this single comment for her mom and also for us as a team meant that it had all been worth the effort. And with that, I think we've covered our exciting journey with the CamAPS system. To conclude that we have to overcome clinical inertia and get out of our comfort zone, that the best way to learn how to use any technology is by actually using it, and that I really believe we need to give choices to people with diabetes and to adapt to their needs and circumstances. Thank you very much for your attention.
Thank you, Pilar. Wow. And really that echoes our own experience. And yeah, I've not done a head count properly, but I think I've managed somewhere. When I last did it, it was 150, but it must be now closer to 250 women on hybrid closed-loop systems. But actually, I've not learned any more. The learning is exactly as Pilar says in the first few patients, and then it's easy. I think we are actually on time. So if there are any questions, please come up to the microphone, introduce yourselves. If you're shy about doing it now, email us afterwards. It is as Pilar says, you learn it by doing it. And it's not hard. Anyone brave enough to come up and ask a question? Yeah, please come to the mic.
Is there a cost involved of using the app, or is it free to the user?
It depends really on what. So the question was, is there a cost involved in using the app? So our planned implementation across the NHS in the UK is that we will have a cost that is for the entire system. So that will include the pump, the app, the sensor, and the phone. And we know from the concept trial that just using CGM alone saves the NHS approximately £24 million per year. The treatment difference with hybrid closed loop is many-fold greater. So we expect any cost to be trivial compared to the cost savings. And, you know, yes, we can cost things like neonatal care unit admissions. We cannot put a cost on some of the experiences that Pilar has just mentioned. And, you know, we cannot put a cost on saving babies' lives. We've estimated how many babies' lives would be saved per year, and it's between 90 and 100. Yeah, you can't put a price on that.
Hello, Carmen Quiros from Barcelona. Thank you for your presentations. They are very interesting. And I have a practical question for Dr. Murphy. Do you use Dexcom 1 or Dexcom G6 or Freestyle Libre, especially in pregnancy? Do you have experience with both? There are any differences?
Yeah, so, I mean, the question is, are there any differences between the sensors? I mean, I can't give you a good answer because in my clinic, we exclusively use the Dexcom G6. Pilar has used both, so maybe you want to comment?
Our experience is very little to compare. Actually, some of the women switch from one sensor to the other, depending of the phone compatibility and so on, but we don't have data enough to compare.
If there are no other questions, then yes, I'm delighted to draw this session to a close. We will be talking more about pregnancy-specific hybrid closed loop in the Diabetes special tech session at 1:30. And a lot of what Pilar and I have said is already available online. So yeah, overcome your clinical inertia. This is not difficult, and it is life-changing for our patients. And it is an enormous privilege for us as healthcare professionals to do what we do in this era of ever-improving technology. So good luck, enjoy using it in your clinics, and make a real difference to the lives of women and babies. Thank you.